This is a CT scan. We can start by AP view showing transectal component of anterior column fracture, which is minimally displaced at articular surface and more displaced at the pelvic brim. If we go through a virtual iliac view, you can recognize that there is a low fracture of the posterior column with an intact most of a greater sciatic notch and a stable ilium. On the obturator view, there is a bit higher fracture of the anterior column, but there is no comminution. One of the advantages of the 3D CT is an end-on view of medial wall. So now we can see a vertical component of the T-shape together with transverse component which runs from inferior posterior to superior anterior. And now the debate is, should we open anterior first and fix anterior column and try to fix posterior column from anterior approach through stopper window? But when there is a posterior wall fragment or comminution, this approach will not be helpful at all. You can see that there is a large posterior wall fragment, which is the main weight-bearing area, which is needed to be buttressed. And therefore, we know that we are going to go for posterior approach, mainly for two reasons. First, more comminution of the fracture line. Second, we have a posterior wall. Third, if we have a posterior dislocation. Our sequence of reduction is, we will try to fix the ischium into the greater sciatic notch, and we will use the window of the posterior wall to have an intra-articular view. So the tip is that the femoral head should always be congruent to the articular surface of the acetabulum. So we will use the intact femoral head as a template for the reduction of the acetabular part. So we will try to reduce the ischium to the greater sciatic notch in order to reconstruct the ischial spine. And then after this, we will fire a temporary fixation K-wire perpendicular to the fracture line. This is the fracture site, so the wire will go from proximal to distal, and from up to down, and from stable fragment to unstable fragment. After this, we will reconstruct and reduce the posterior wall, making sure that the two ends of the fracture, which is the proximal part and the posterior part, are aligned accurately, making sure that this comminution will be reduced properly back into the position. Although this is an extra-articular fragment, but it is very important to put it back in place to complete the puzzle, to make sure that the intra-articular fragment is okay. Then we will fire a K-wire to have a temporary fixation, and then we will use a reconstruction plate parallel to the articular surface to attach the ischium to the previous, and then we will fire an intra-fragment screw perpendicular to the fracture line through the same place that we put the wire in. And now our attention is directed to the anterior column. As you can appreciate, the anterior column is somehow reduced. We will just aim our reduction through the Matta clamp, and then we will try to fire an anterior column screw. For the anterior column screw, basically you have two views, just like this view we have, which is II view, iliac inlet view. So our main aim for the screw is to be within this V-shape angle. So the screw entry point will be along this line, a line here, one of this point in this line, which is connecting the top of greater sciatic notch to the interspinous part of the ilium between anterior superior and anterior inferior. So this is the line. So from this you can appreciate even more closer view. This will be our entry line, and then we will take another perpendicular view, which is obturator outlet view or view to make sure that the screw is extra articular and in line with the long axis of the anterior column. After we took these two views, we will try to take more perpendicular views. Make sure that our entry point is okay and our corridors are okay, and then we will go with the screw. So let's see what will happen, inshallah.